Hi viewers, welcome back. Let's dive into a summary of a study by Dr. Fakih-Gomez and colleagues outlining a novel technique for the non-surgical correction of tear trough deformity. The tear trough is a common cosmetic concern that impacts people of all ages. This study introduces a non-surgical method for addressing this concern through the use of dermal fillers. Additionally, the study outlines the anatomy and classification of tear trough deformity, as well as introduces the suborbital retaining ligament, subseptal, and retroseptal spaces as vital anatomical landmarks for accurate filler placement using a microcannula. The novel technique was applied to treat a total of 620 tear troughs across 310 patients. The average volume of filler used per eye was 0.35 cc, and patients required a median of 2 treatment sessions. Overall patient satisfaction was high, and no serious complications were reported. The need for a standardized injection technique to reduce complications and improve outcomes was emphasized. The technique. The detailed technique involves identifying specific anatomical spaces for filler placement based on the type of deformity. To address volume deficiency, authors advise for the placement of filler in the retroseptal space. This strategy is aimed at restoring volume to the specific area affected by volume loss. By filling the retroseptal space, the filler is strategically placed to provide support and smooth volumization to the lower eyelid region. Now let's walk through the technique. Begin by marking the entry point at the intersection of a horizontal line from the nasal base and a vertical line passing through the lateral canthus. Use a 25 gauge 38 mm cannula for filler placement. Apply local anesthesia at the entry point and use a 23 gauge needle to create the entry point. Insert a bent cannula at approximately 135 degrees deep through the skin and smash into the premaxillary space. Then advance the cannula towards the tear trough, identifying the orbital retaining ligament and orbital septum. Place a small amount of filler in the suborbital retaining ligament space to numb the area and facilitate painless penetration of the orbital retaining ligament. Lift the cheek with the non-dominant hand to relax the orbital retaining ligament for easier penetration. Redirect the cannula posteriorly towards the floor of the orbit, encountering the orbital septum. Penetrate the orbital septum to enter the retroseptal space, aided by positioning the patient in an upward gaze. Confirm the cannula's location by considering the orbital retaining ligament and septum as 2 sticks, free movement in suborbital retaining ligament, limited movement in subseptal space, and impossible elevation in retroseptal space. Undercorrection is recommended due to filler's water retention properties. Reevaluate patients after 2 weeks for minor retouches if necessary. The use of a specific type of filler, cohesive polydensified matrix-based hyaluronic acid filler, CPM-HAB in short, is recommended for achieving optimal outcomes in this regard. The use of CPM-HAB is recommended based on its specific properties that contribute to favorable results. The cohesive polydensified matrix provides higher dermal integration, which is essential for achieving a natural and seamless appearance following the filler placement. Additionally, this type of filler has been associated with a non-inflammatory response, reducing the likelihood of adverse reactions or complications. Importantly, CPM-HAB is noted for its ability to prevent the Tyndall effect, which can cause a bluish tint when certain hyaluronic acid fillers are placed near the skin's surface, particularly in patients with thin, lightly pigmented skin. The authors discuss the limitations and challenges associated with non-surgical correction of tear trough deformity and emphasize the importance of patient selection, management of expectations, and understanding the limitations of filler treatments. The need for a combination of surgical lifting and revolumization for more severe cases of tear trough deformity is highlighted. In conclusion, the study presents a consistent and reproducible technique for non-surgical correction of tear trough deformity, providing specific anatomical landmarks for precise filler placement. The authors recommend adopting this technique to minimize complications and achieve high patient satisfaction. Thanks for listening. Let us know which topics you'd like us to cover in the comments. And see you in the next bedtime story.